joining in as we start. So Millie, thank you so much. So good morning, everybody. Good afternoon for those joining from far. Thank you for joining us this morning as a good friend, Simon Ecclesall, talks to us about the DCB-Only concept. For those of you who don't know Simon, he really has become one of the most prominent people in coronary intervention, particularly with drug-coated balloons. And I continue to learn from him. And I thought it was important for us to start talking about this concept of not putting metal scaffolds. We spoke about it a few years ago with BVS, and then BVS didn't turn out to be what we hoped for. And I think drug-coated balloons could potentially fill that gap and be how we treat coronaries in the future. So Simon, it's all up to you. And thank you so much for taking time out of your day.
Oh, brilliant. Thank you very much. Thanks for the invitation. It's always a pleasure to talk about DCB-only angioplasty because I could talk endlessly, but I won't talk endlessly today. So my name's Simon Ecclesall. I work at Norfolk and Norwich University Hospital in the UK. I'm going to give you a little bit of an overview of why perhaps we don't want to put metal inside people's coronary arteries. And in the time-honoured fashion, I'm going to start by showing you some pictures. So it will work. We're going to go on to a case. So this is a 41-year-old man who presented to a rapid access chest pain clinic with angina. He had a CTCA which showed some left mainstem disease and a reportedly tight ostial left anterior descending artery lesion. He had an echo which suggested anterior hypokinesia. Now, his story is a lot more complicated than that, in that he had an inherited telomeropathy with pancytopenia and had been having platelet and blood transfusions since 2015. He also has disc keratosis congenita, subpleural interstitial pulmonary fibrosis with upper lobe honeycombing and widespread ground glass appearance in the lower lobes. And on top of that, he has multiple PEs. So as you can see, he has all sorts of things going on that would make coronary intervention really not particularly easy. So this is one of our trainees taking a very gentle injection because they were so anxious about what was going on in his left anterior descending artery. They did take a full set of diagnostic pictures, then took the patient off the table and went through an MDT. So hematology said it was very difficult prognostication for this gentleman, but I think essentially we're saying that he did not have a good long-term prognosis. Surgical revascularization was therefore not an option for the above reasons. And eventually in the MDT, we felt that PCI would be reasonable if it was technically feasible for symptoms. And again, with the proviso about whether or not prognosis was relevant here. We decided it would be a 2-operator case. So I was going to do this with one of my colleagues, essentially because what we were trying to do is a DCB-only angioplasty. And you have all the ongoing problems of we had to do it uninterrupted on anticoagulants. He was having transfusions, and then you got this discussion around what antiplatelets you may or may not want to use. So these are the better diagnostic pictures with a guide catheter. As you can see, he does have distal left mainstem disease. He certainly has a very tight ostial LAD lesion. And I guess the thing that now springs to mind, now that we can see all of this better, is this actually a true 1-1-1 Medina bifurcation? So the plan had been that we were going to do angioplasty of the LAD plus or minus involving the distal left mainstem only. We were then worrying about the ostial circumflex. All these vessels are big, but they were imaged successfully with intravascular ultrasound, which confirmed they were all at least 6 millimeters. The ostium of the circumflex was wide open, and there was significant distal left mainstem involvement, but not as tight as the ostial LAD. So we went with a rather unusual approach. We were planning to not put stents in, so we've wired both vessels. We've got a 2.5 non-compliant balloon into the LAD lesion. We then went with a 4.0 non-compliant Scoreflex at quite high pressure. We then used a 4.0 DCB, bearing in mind we know that we're treating a 6 millimeter vessel. The result of this still showed significant residual stenosis. So rather unusually, we then post-dilated very gently with a 6-0 non-compliant balloon. So this is the acute result. In the cranial shot, you can see that the left main stem's opened up nicely. In the caudal shot, there is somewhere between 30 up to perhaps 50% recoil at the ostium of the LAD. And there's the wire out shot at the end of the procedure. Down the right-hand side of the screen, you can see what we now call our DCB checklist that we use for all of these cases. It's broken down into 3 parts. There's the lesion preparation part, the safety part related to whether or not you need to bail out with a stent, and then the use of the DCB. And the bit we're particularly interested in here, obviously, is the safety. So the patient is well, no ECG changes, no symptoms. It has TIMI3 flow. There is no progressive luminal compromise of the LAD, although there is a degree of recoil. We can't see a vessel-threatening dissection, and in particular, there's no contrast that's accumulating and hanging up in the wall of the treated lesion that would suggest possibly an intramural hematoma. So that was the end of the procedure. As he was young, and what we'd done was really a rather complex procedure, or certainly complex anatomy, we elected to bring him back at 3 months. At this point in time, he was angina-free, but we felt it was important to redefine his anatomy. So you've got, hopefully you can see on the left, pre, in the middle is post, and on the right is at follow-up, and you can see that he's already got positive remodeling, or the late lumen gain that you get with paclitaxel drug-coated balloon-only angioplasty. So the conclusion to this short introduction to the talk is that we've had a very simple solution to what was a rather complex case, that the DCB-only approach allows simplification of the procedure and antiplatelet therapy, for example. Late lumen gain is a big advantage with DCB-only angioplasty. I don't know whether perhaps you want to discuss now about anything that I just showed you in that case before I then go on to talk a bit more about our DCB program.
Yeah, maybe that would be great. I'm also allowing a lot of our fellows to talk and join the discussion, some of our attending. So I think it's a great discussion. So if any of you had a comment, that would be great. So, what we would have had to do here, I'm just trying to think, what we would have had to do in our practice here, because we don't have DCBs, is probably try to be provisional, put in a single stent, onyx from left main to LAD,
Yeah.
right? And give Plavix and anticoagulation, I guess, for 1 month. I mean, well, I guess we wouldn't give triple therapy. That's what we do. But, the thing that always worries me about that is when the patient then 2 weeks later has a bleed, right?
Yes.
What do you do when
Yeah.
there's a new stent there, and not even a month has gone by?
Yes.
It's very concerning. So I really like the approach. I have to say, I think for many people thinking about doing left main with a drug-coated balloon, de novo left main, they feel uncomfortable because, and maybe you can just talk a little bit about your experience, because I know you've done large vessels. They feel uncomfortable, I guess, because what happens if you get a dissection? So
Sure.
if you have a bailout plan, say you dilate and you got a dissection.
So, okay, as we both know, that there are all sorts of dissections that you can safely leave, and then there are the vessel-threatening dissections that undoubtedly you have to stent. And the reason why we did this as a 2-consultant case was we were trying really hard to not end up having to bail out with the stent because of all his comorbidities and bleeding problems. Now, I'll show you some of our data, but having been working in the DCB field now for 10 or 15 years, we've got very comfortable with what dissections are safe to leave and which ones you can modify, and then which ones you undoubtedly have to go ahead and stent. We've done a lot of large vessel work. We've published quite a lot of registry work on it. One of our more recent ones was actually a left main stem cohort in which we propensity matched de novo left main stem with DCB treatment against stent treatment, and showed numerically that all the event rates were lower in the DCB arm than in the stent arm. Tumas Rasanen, who we both know as well, has also published another left main stem cohort. And his emphasis there was on really good lesion preparation, giving you very good long-term outcome. That's the sum total of the published left main stem data, but there's a lot more registry data, particularly in large vessels.
Okay, well, maybe let's move on, and I'm sure the team will have a lot of questions for you by the end.
Okay, I think that first case was a bit extreme and a bit provocative to try and set the scene. So I'll go on with the rest of my talk. So I've got a few conflicts first, perhaps, that I should own up to. I don't like stents. I'd like scaffolds even less, but I think watch this space is probably the best comment there. I still like my angioplasty, and I really like my drug-coated balloons. So a short history of angioplasty from my point of view. Angioplasty was first performed in 1977. The early registry data showed acute vessel closure rates of 4% and vessel-threatening dissection rates of 9%. Bare metal stents, first published in 1987 in the New England Journal of Medicine, were specifically a bailout option for acute vessel closure, vessel-threatening dissections, or acute recoil. Because of the ongoing problem with restenosis after balloon angioplasty and after some years of work, back-to-back publications in 1994, again in the New England Journal of Medicine, with Benistent and Stress, showed that a standard approach of stenting, bare metal stents, rather than balloon angioplasty, drove a much lower restenosis rate across the board. So as a result of that, people started putting stents in. We then realized actually there was still quite a big restenosis rate. We then developed drug-eluting stents. The first generation, Ravel and Taxus, showed significant reductions in TLR, all drive the reduction in MACE rates that you see. After that, I think we've ended up in what I would term stent wars, with all the different companies trying to get better drugs, better platforms, less polymer, etc. So where are we now? Well, over 90% of all angioplasty is done with drug-eluting stents, although everybody accepts that there are ongoing problems with in-stent restenosis. Between 5 and 10% of all our angioplasty occurs for in-stent restenosis. And there's this ongoing problem of stent thrombosis that is picked up in, for example, the SCAR registry. And currently, scaffolds are doing worse than any drug-eluting stents. So who needs a stent? Well, originally it was for acute bailout of balloon angioplasty problems. Then we discovered that it would reduce our restenosis rate. But if you don't have an acute problem, so you don't need to bail out with a stent, do you really need to be putting a stent in at all? And is there any other way of going about achieving the problem and of sorting the problem? And actually, some of these problems we are now generating by leaving this long-term implant in. So if we go back and look at the data in a bit more detail, this is Benistent. Now, bearing in mind how big the studies are now that we have to use within interventional cardiology to drive our current practice, in the Benistent study, there were 250 patients in each arm, so a very small study by modern standards. Interestingly, in the balloon arm, only 5% of patients were bailed out with a stent. So if you flip that number on its head, 95% of all patients can safely leave the lab without having had a stent. When you look at the two groups at 7 months follow-up, you can see that there is numerically more complications in the group on the left, but actually a lower restenosis rate. That's because this is the stent arm. So we're trading off more deaths, more MI, more urgent and elective bypass grafting for a lower restenosis rate as compared to the balloon-only angioplasty group. The difference in bleeding is because at this point in time, we didn't have dual antiplatelet therapy, which makes the balloon angioplasty group results look even more impressive. But we were also still in the dark ages of large caliber sheaths, the femoral artery, and anticoagulation instead of dual antiplatelets. So if we then look at the Stress paper again, one of the safety outcomes that everybody's interested in is acute vessel closure rates. Well, they reported something called abrupt vessel closure rates, 2 to 14 days post PCI. So everybody will tell you that they remember the old days before we had stents and all those vessels that went down in the middle of the night. So in this study, 7 out of 205 in the stent group had an abrupt vessel closure, 3 in the balloon group, but all of those were after bailout stenting. Vascular complications, again, were higher in the stent group for the same reasons. So that's not so convincing when you look at the data that way. So maybe we need to look for a bit more data. So there's a very large Bayesian meta-analysis comparing angioplasty with stenting that was published in 2003. Now, I don't think most cardiologists have even heard of the Annals of Internal Medicine, and they certainly wouldn't be reading it. And I do wonder why this got published there rather than anywhere else. We can maybe discuss that later. But what did they do? They looked at 29 trials, so 10,000 patients. And this is a standard balloon angioplasty approach against a standard bare metal stent approach. And sure, the restenosis rate was reduced, but there was no difference in death, MI, or the need for bypass grafting at 6 months. So what this is telling us is that there's no prognostic benefit in routinely stenting all of your patients. So maybe we need to look elsewhere. What about primary angioplasty? That's a really high event rate group, and we know that we're saving lives there. So in 2014, a group in the States published their outcome from primary angioplasty, excluding stent thrombosis, over a 20-year period. So they had 600 balloon angioplasty patients in this group and 1,500 stents, the vast majority bare metal stents. So the balloon group was older, more women, more 3-vessel disease, more small vessels, all markers of a worse angioplasty outcome. At 12 months, there was no difference in those endpoints I've shown you there, although there was a trend to a reduction in lesion thrombosis in the stent group. And then at a year, there was no mortality benefit again. After that, they did a landmark analysis, and then they started following these patients out for longer. So if you look at stent or lesion thrombosis, at a year, the balloon group is doing slightly worse, but you remember they were only using balloons because they didn't have stents that they could bail out with. So of course, they're going to be running into problems anyway. But from 1 year out to 9 years, the lowest event rate group is balloon angioplasty. The next lowest, bare metal stents. The worst, drug-eluting stents. I'll show you another one. Target vessel reinfarction, virtually exactly the same results. So what are these saying to me is, at long term, the less you leave in the blood vessel, the better. If you have coronary artery disease, you will have an attrition rate, but it's lowest in the balloon angioplasty group because there's nothing left behind. As soon as you start leaving metal or even slightly toxic polymers, like we had on some of the early drug-eluting stents, your event rates get higher and higher. Now, one of the arguments here is the stats behind all of this. And as you can see, the drug-eluting stent group were around for a shorter period of time and have much lower numbers, as you can see running along the bottom. So a lot of people would discount this, saying that actually it's an unfair comparison. So most of you will probably have seen this paper at some point in time, which is a huge meta-analysis of thousands of patients. And what's it showing? Up to 12 months again, that there is this ongoing attrition rate with target lesion failure and major adverse cardiac events across all stent types. And if you look at 5 years, there is no plateauing. So at 5 years, you have an attrition rate from everything that you've left behind in that blood vessel. So maybe we can accept 5 years, and people would say, well, okay, that's acceptable, and after that, it will be fine. Unfortunately, that's not the case either. This is a Euro intervention paper I found from 2018, comparing proximal LAD stenting against any other vessel being stented. At 10 years, deaths, TLR, and definite stent thrombosis are still not plateauing. So the longer these bits of metal are in your coronary artery, the more event rates you're going to have, and there doesn't seem to be any end in sight. So perhaps, hopefully, we all agree, drug-eluting stents have no prognostic benefit over balloon angioplasty. Permanent implants maybe aren't the best long-term solution. So if we can treat restenosis in some way, maybe we've got most of the answer, and that's where the DCB-Only concept comes from. So I'm now going to take you back in time in a different way to when we first started using drug-coated balloons. So before they were CE marked in 2008, we used a few for patients with in-stent restenosis. As soon as they were CE marked, we got them on the shelves in 2009, with increasing use in, first of all, in-stent restenosis and then small vessels. And this is the natural progression that happens anywhere with this sort of technique. Is it starts with an in-stent restenosis treatment, then you go to small vessels and side branches of bifurcations. And then, as you can see further down the screen, we then moved into de novo work and then increasingly large vessels over time. And I think there's very much a learning curve related to all of this and an adoption rate as well. So in 2013, these are my DCB cases per total per month. So for the second half of the year, I was obviously a convert. So what happened in that year? Well, I was fortunate enough to go to some DCB meetings in Europe. I then went to Potsdam and Saarland to visit people like Klaus Bonaventura, Franz Kleber, and the godfather of drug-coated balloon angioplasty, Bruno Scheller. Went into all of their labs and watched what they were doing, and I was absolutely blown away by the fact that they were leading all of these dissections and just angioplasting people safely without putting stents in. And it's a real change in mindset, I think, to see how people do that and then understand the advantages behind it. I then came home thinking I wanted to try and start performing drug-coated balloon angioplasty in our centre in a much bigger way. So what happened after that? So this is my stent adoption rate, stent adoption use going down, and my DCB adoption rate going up, mirroring each other over the next couple of years. And you can see that I went up to around 50% of each over 2013 to 2014, and then from 2015 onwards, the rate went up again. And I think this was related to technique and some comfort and awareness of the results that we were getting and how safe it was. So at this point in time, in most talks, people say, well, he's mad. So fortunately, those are some of my colleagues who over the same time course started taking up more and more DCB as well. And me over the next few years then from 2014 to 2017, as you can see that my DCB rate went up to 80 and then over 90%. So top right, you can see that I was only not DCBing at around 5%, which is very similar to the Benistent bailout rate that I showed you back at the beginning. So departmentally, by 2015 onwards, for the next 3 years, we were using drug-coated balloons and drug-eluting stents at a ratio of 1:1, so 50% of each. So as you're probably aware, in the UK, we are very closely monitored. We have to submit every single angioplasty to our national database, which is called BCIS, that then interacts with NICOR, which is the National Institute for Cardiovascular Outcome Research. So we every year have to go to a meeting in London in January, whereby we look at all of our audit data. So in 2015, this was the audit data showing drug-eluting stent use per centre. As you can see, nearly everybody is up at the top. That year, we were down here, and they had to actually change the y-axis in order to fit us in. That's BCIS coming to look at us because we're a bit of an outlier. So how are we an outlier other than not putting in stents? So we are judged on our 30-day mortality for all of our angioplasty across the board. It's risk adjusted, and it's looked at by operator and by centre. And if you are an outlier, you get either a telephone call or a knock on the door. So over the 3 years that we were DCBing and stenting at a 50-50 rate, BCIS came out with 3-year data for our 30-day mortality. So risk adjusted, we should have been at this point. So patients should have been surviving at just under 98% of the time. So if we were really good, we might be 2 standard deviations better. We were actually even outside that. So we were fairly comfortable that we were doing safe angioplasty with good long-term outcomes. Around the same time, we started publishing our first, or presenting our first work. So this was at both the London meeting and then PCR in 2015, showing primary angioplasty with drug-coated balloons, chronic total occlusions, treating the lesion as well as the distal vessel with our DCBs, and then our early left main stem data. And obviously this was now quite a few years ago. We moved on from there. One of my favorite bits of data that we've found so far was really pushed by the whole safety concern over paclitaxel with the Katsanos status that came out a while ago. So we went away thinking, well, we have this enormous database of patients. We know our outcomes. So what actually does happen if we're using paclitaxel or if we're using limus stents? So we tried to find the cleanest cohort that we could. So these are people that had not had a previous angioplasty, not had a previous heart attack, and were elective rather than ACS patients. So we found the two groups. We then propensity matched down to 429 in each group. And this is their survival probability over months plotted out there. And as you can see, there was a significant difference between the two, with more stent patients than more DCB patients not surviving. So in the UK now, we are gradually shifting so that on the left-hand side of that chart, you can see more recently how a number of centres are starting to use more and more drug-coated balloons as a percentage of all of their angioplasty. So where next? I haven't shown you all of this, but there's lots of small single-centre work on DCBs. There are large registries and there are randomised trials, majority of which are in small vessels. And obviously, Azim was hugely involved in the Bellow study, which is a very early, very impressive result with the Impact Falcon, which is the equivalent of Medtronic's current Prevail balloon. So the next big step, and what everybody's crying out for really, is de novo big vessel RCTs. So in the next few minutes, I'm going to very quickly talk you through this bit of the landscape. So ongoing and imminent RCTs, but also the limus question, because this has become a bit of a hot topic. I'd like to thank all of these people for involvement in any of the future, the slides are going to show, and some of the future trials that I'm involved with. And it's a bit of a roll call really of a lot of DCB angioplasty people from around the world. So what's out there from the point of view of limus? Well, there's a number of balloons. The main ones at the moment, I would say, are Magic Touch, that you may well have heard of, that have done a number of trials. They did Transform 1 that was supposed to be presented at PCR but was withdrawn, and we're waiting to see that data. There's a Solution sirolimus balloon that I'm involved with, a Solution de novo study in Europe and globally. And then there's B. Braun with their own sequence sirolimus balloon, who have some small trials, and we're waiting to see whether they are going to go with a large trial, large vessel with sirolimus, or with their paclitaxel balloon. So very briefly, some of the sirolimus work. This is thanks to Bernardo Cortese, who was involved in Transform 1, and this is their Transform 2, which is a much bigger, all-comers, larger vessel study. And like a lot of DCB work, the idea is you do lesion preparation first. So you need to get a minimal residual stenosis, no vessel-threatening dissection, and TIMI3 flow. So this is randomization after lesion preparation. So I would call this a device randomization trial. And it's randomized between everolimus stents and the Magic Touch sirolimus balloon. The next one is the debates trial from Thomas Rationale. Now, he earlier on published a fantastic study called the Debut study, which basically showed that in high bleeding risk patients, which is his real interest, that drug-coated balloons absolutely, for want of a better scientific word, annihilated bare metal stents at 9-month outcome. I think the field has now moved on, and those companies have moved on, and they've got very aggressive short dual antiplatelet therapy for their drug-eluting stents. So he's gone with another trial with an even more aggressive antiplatelet therapy regime for the drug-coated balloons of perhaps only single antiplatelet, or at most 1 month dual antiplatelet therapy in the ACS. And then following essentially, I think he's following what the companies would recommend for their drug-eluting stents. So 1 month of dual antiplatelet therapy in stable patients. So that's already started. The Solution de novo trial, that's the one that I'm one of 2 global PIs with Christian Spalding on. This, when we finish it, will be the largest DCB trial out there, 3,300 patients. One of the things that I really like about this is it's randomized before the procedure. So I would call this strategy randomization, whereby you look at the angiogram and you decide either you can treat everything with DCB or you can treat everything with stents. And if the answer is yes, then they get randomized to one or other arm. If you have to bail out in the balloon arm in one of your lesions, they still stay in the balloon arm for all their other angioplasty. And it's nearest to an all-comer study that I think currently we're going to get. It can't be left main stem or vein grafts or CTOs or ISR or ST elevation infarcts, but it will certainly be large vessel. So this has been recruiting now for a while, and we've enrolled, it's now currently over 1,300 patients. Pretty much every type of vessel, lots of LAD, so hopefully that means big de novo vessels that will give people some comfort when we come out, hopefully with good safety data. As you can see, over 60% in the DCB arm are over 3 millimeters in diameter. And the bailout rate, we had expected anything less than 30% would be acceptable as the bailout rate for this study. And currently we're running along at around 20%. One of the other big studies on the other side of the world is Prof. Shin from South Korea. And this essentially is the next B-Braun large vessel drug-coated balloon study. And again, this is randomization after lesion preparation, and it's using the paclitaxel balloon from B-Braun. Other ones that are in discussion, Rabin Jaeger, who published Basket Small 2, as in the small vessel B-Braun study, that showed non-inferiority at 1 and 3 years. The great name for his next study, which hopefully will be a big vessel study on the European market, should have been basketball for either big or all. Probably won't be that now because Rabin's actually moved hospitals, but that's one of the studies that is currently in discussion. Another one that I'm very excited about, because I think DCBs are just made for bifurcations, is some work with the European Bifurcation Club on an all DCB strategy against an all drug-eluting stent strategy, randomized for true bifurcations, well, for bifurcations. So I think I've talked for long enough. Perhaps we should have some discussion now.
Thanks, Simon. That was a great overview and sort of justification of why you've chosen to go to a DCB only strategy. I didn't realize, I mean, I knew you did a lot of de novo disease, but I guess I didn't realize that you are now over 90% DCB only for your cases, which is really remarkable. So maybe you could stop sharing and we'll get some of the team on. I've asked a lot of our, here we go, hang on a second, let me do this better. I've asked a lot of our fellows and faculty to join and ask some questions. So I'll just go by how I see them on my screen and who lifted up their hands first. So Matteo, let's start with you. You're still on, you're on mute, Matteo.
All right, can you hear me now? Better?
Yes.
Okay. Hi, good morning. Thank you for a really great talk. Coming from the US, where the drug-eluting balloons are not approved yet, it's like good to hear these stories from Europe. I'm curious how you see the platforms changing in the future, and like what we have to look forward to, because I mean, maybe in 5-10 years.
Okay, so my view of generally of where angioplasty will be going in the next 5 or 10 years is, as you probably guessed from my talk, a little bit biased. I would suggest that we need to redress the balance and we need to move away from stenting the vast majority of our patients. I think in 5 or 10 years' time, we will end up in a place where the leave nothing behind approach will drive the majority of our angioplasty, and I would hope that we would be using drug-eluting balloons of a variety of formulations in the majority of our cases. I think it should be the #1 destination therapy for angioplasty, and I think after that we would then end up with Drug-coated balloons is over 50%, perhaps 60 or more. Scaffolds, I think, will take up some of the rest of it, because if you honestly buy into the leave nothing behind concept, and we can find scaffolds that actually have good early safety data and then the long-term efficacy, that would certainly be reasonable in young people. And I don't think I've ever actually said this before, but I think stents will become the niche product. I think it will flip it on its head. What do we need to look forward to from the point of view of there's loads of developments. There's so many more things happening with all sorts of different balloons out there. I think the things that need to be worked on with some of the balloons is deliverability. Some of them are still surprisingly undeliverable sometimes. Some of them are a little bit sticky and don't like going round some bends that you would expect to deliver a stent round. But the fact that there are so many companies out there and so many bits of development and research going on suggests to me that this is a really hot topic, and it's now a tidal wave of interest and change in practice.
Well, okay. So we're going to see lots more drug-coated balloons. I like it. I love it. Julio.
Good morning. Thank you for this wonderful. So the first case was very impressive, the final outcome. I have two questions. The first one is in the technical aspects. How should the inflation and deflation of the DCB perform? And my second question is, do you do by routine intracoronary imaging after PCI using DCB?
Okay, I'll answer the second one first. That's a very quick answer for me, which is no. And that's because currently there is no data on how to interpret imaging after drug-coated balloon angioplasty to give you particularly the safety aspects long term. I mean, there are some people who are very good at imaging that probably could predict those dissections which are safe to leave and what would be an efficacious long-term result. We and most DCB operators around the world have learnt all of their DCB angioplasty based on interpretation of the angiogram only. And actually, there is a lot more on the angiogram than perhaps most people appreciate from the point of view of interpretation of what types of dissections are safe to leave, which ones you can actually modify. We've now discovered that with repeated use of scoring and cutting balloons, you can turn a vessel-threatening dissection into a safe dissection. So there's a lot more information on the angiogram. There is a lot of interest because I think, certainly with stenting, I think it's now reasonable that and accepted that most stenting benefits from image guidance and image assessment at the end. And I think people are trying to work out how that translates over into DCB angioplasty. Your first question was about, I didn't quite catch what you said.
No, it's how should be done the inflation and deflation of the DCB. It's the same with, for example, with sequence, solution, Magic Touch is the same way. When you tell me if I haven't answered correctly, because I didn't really catch it. But from the point of view of the drug delivery, each different company has different instructions for use as to how quickly you're supposed to get the balloon there. So as soon as you put it into the patient, what's called the transit time, from when it enters the patient until you deliver it, most of the companies generally would say that that's got to be under 2 minutes because you have a wash off of the drug. Delivery time, which is the inflation time, again, will be specific to each company and each drug, and you need to look at the instructions for use. The majority of them, however, would say a minimum of 30 seconds, and we use 30 seconds as a fairly standard for our balloons. Some of them say up to a minute, but I think with all of them, you probably delivered enough of the drug within the first 30 seconds, and that isn't actually that long. But all patients can tolerate 30 seconds, and if they can't, you will have discovered that when you're doing your lesion preparation. And in fact, you can almost precondition them with the lesion preparation part of your angioplasty. How you deliver it, one of the really important things to get across when you start using drug-coated balloons is you're not doing angioplasty. It's only about delivering the drug. So it's a slow, gentle inflation just to touch the sides, really.
So all your angioplasty has got to be done up front with your lesion preparation balloons, and that can be anything. So we use lots of scoring balloons, IVL, we use rotablation, you name it, any type of lesion preparation out there, as long as you get a safe angiographic result. And then the DCB is only to deliver the drug.
So, yeah, I want you almost to repeat that, because this is part of the education that will have to happen in the US as we're getting DCBs. I often hear this, concern. Oh, I did forget, balloon angioplasty. I'm still struggling there to get people to understand that the whole concept of geographic miss isn't really relevant anymore. Because there was this old concept that whatever you ballooned, you had to stent, right?
Yeah.
And if you got restenosis, it was because of geographic miss. I mean, it's so outdated, but people still say this, particularly in the United States, where we haven't had access to drug-coated balloons, right?
Yeah.
When I look at, how long it's been, I mean, you've been using DCB only from 2013, and we still don't have them yet. So there's a lot of education we'll have to do when these become available. But the one where I often struggle to convince people is the atherectomy one. That if you do atherectomy, you don't have to stent afterwards. And I often remind people that all the initial atherectomy studies were done in the balloon angioplasty era, before stents were even available. And so it was balloon angioplasty versus balloon angioplasty and atherectomy, right? And it's not like we had all these acute vessel closures in that atherectomy arm. We actually probably had less.
Yeah. And actually, we all know the term rotor regret, and you have rotor regret in DCB land as well, in that sometimes when you've hammered it with all your specialist balloons, you end up with that dissection that there's absolutely no way that you're going to avoid stenting it. And actually, atherectomy earlier on in the procedure can save a lot of time and get you the good result that you need.
Right.
And that's been, Thomas Rationale, again, he's already years ago published safety data on rotational atherectomy and drug-coated balloons.
Right. Great. Manav?
Thank you very much for kind of challenging the way that we think about PCI in the modern era. I think for a lot of us here in the States, especially, PCI has become synonymous with stenting.
Yeah.
That case you've shown and the data you've shown us have really challenged how we think about that. So thanks first and foremost. Secondly, when you're trying to decide on a balloon or stenting strategy, or maybe one of your 50-50 colleagues, what parameters go into that decision making? Is intravascular imaging before one of those parameters? And is there a lesion subset morphologically that you might avoid DCB, or that you might be particularly be fond of using DCB in? Fibrotic, calcific. We see a lot of very calcified lesions, calcified nodules here in the Bronx, with a high prevalence of diabetes and CKD and smoking. So those were some of the concerns I had thinking about treating those kinds of patients. So curious to hear your input on that.
Sure. So thank you. That's a great question. So from the point of view of calcified vessels, within our enormous database that we are still going through, looking at different outcomes, we haven't picked up a signal that heavy calcification is a marker of a worse outcome. And I think the worst outcome that you'd probably be looking for would be a higher restenosis rate in that case. It is actually one of the things we're going to specifically go back and look at next. We've worked our way through STEMIs and bifurcations, which are my favorite, but calcification is another one. And I think, there are two aspects to this. I think one is, where do we think we're delivering the drug? If you've got plates of calcium, it doesn't seem to make any sense that you can possibly be getting the drug outside that plate of calcium. And therefore, perhaps you're not going to get that late looming gain that I, for example, showed you, and which paclitaxel drug-coated balloon angioplasty almost relies on. And
in all the series that are out there, if you've got a paclitaxel balloon that works, you will get late lumen gain in 60 to 70% of all of your cases. So what that's taught us over the last 10 years, that we can leave things like the case I just showed you with maybe up to 50% residual luminal narrowing, because we know that with the healing process and with the use of the paclitaxel, we're going to get the late gain. So if you're not going to get the late gain because you've got these big sheets of calcium there, perhaps the answer is that you can't rely on the late lumen gain. So all you're then relying on is avoidance of the restenotic process itself, which will happen on the inside of the calcium. So you are still delivering the drug to that bit of the vessel. That is based on absolutely no data. It's just my thought process over the last few months, because increasingly people are asking that same question. Now, if you are using a lot of scoring balloons and a lot of IVL and a lot of rotational atherectomy, presumably you are creating a lot of cracks in those calcific plates. So perhaps the more of that we do, the more drug will get through the calcium, and perhaps then we will get better late lumen gain. These are all things that I think are future research projects to some degree.
Maybe sort of one question follow on from Manaf's question, which I think was very important. If we look at the solution de novo study that you're leading, right? Like you said, I thought it was very interesting because it's the first time we truly do a strategy study where you randomize before you actually start pre-dilating a lesion preparation. And I'm sure the randomization or the inclusion differs in different centers, right? Where depending on how strongly they feel about drug-coated balloons. But which patients, I mean, in your practice, would you exclude from that study? Or would you include every patient you see in that study? I mean, obviously, I know you said, STEMIs, left main, and SVGs were out, okay? But taking those away, is there any patient you will not include in the study?
Okay, so we have two, well, in my practice, I've got two issues. One of them is, one of the bits that I probably didn't say is one of the exclusion, because we're looking at target vessels, is they can't be randomized if that vessel has had a previous angioplasty. So that does make life a little bit more difficult. So if they've got a stent in their proximal LAD, we don't want the distal LAD randomized because it might be the stent that's failing.
Okay.
So that makes recruitment a bit more difficult. The second part to that is, because our centre's now been doing this for so long, all of our patients get a huge amount of information up front about our angioplasty program generally, which includes a lot of information telling them, we know what the guidelines say, everybody should have a stent. We've been doing it differently for the last 10 years. There is a lot of data out there. Our safety data is published everywhere. We believe in the whole concept long-term of not putting stents in people for these reasons. So we get people that have never even had an angioplasty before that say, I don't want a stent, I want you to use a DCB. So we're actually getting screening failures for that reason, if that's the right terminology for it, which I think is quite interesting. So once you've got battled your way through all of those and the other exclusion criteria, then yes. And I think it goes back to the previous question that I didn't reply to, which is there a subset that I don't chase with drug-coated balloons? The answer is no. I start every angioplasty going to do an angioplasty, thinking my number one outcome would be DCBs, my number two might be a stent, number three might be I can't even do it safely today and I've done half a job and I'll bring them back, or whatever. But no, I start off every angioplasty not expecting to put a stent in.
Great.
Which fits the whole thing.
No. I mean, so that's the thing. If you are a true believer in the approach, that would be my expectation that your response would be, is that there are no anatomical exclusions for using a DCB. That's what I was hoping to hear, because that that really says you believe in your approach and in this approach, which I commend, and I think is very important. We need to have more and more people like you that push the rest of the field and challenge us, right? Particularly with data. And that's what you've done is you're not just doing it and saying, oh, no, this is the only way to do it. You're saying this is our data as well. And this is, our outcomes. And I think that's extremely important, Simon. We'll give you the last two questions, Simon, before we let you go. Andrea, first.
Hi, first of all, thank you for giving this talk. I was wondering if you could tell us more about the dissections after DCB, rather than flow limiting dissections, which are the characteristics of a dissection you will stent and not leave after DCB?
There's probably a whole talk in that. So there is this, what I now call the old-fashioned classification, which is the A to F one that you will find published and republished everywhere. So the type A and the type B dissections are safe to leave. Type C, there's still a lot of argument about, is it safe or is it not? And anything from D, E, F essentially is not safe and you can't leave them. It's a nice idea as a classification. The problem is everybody puts stents in, so nobody's actually even understands what the classification is anymore. Having done quite a few meetings and quite a few talks, I get a lot of these questions, and sometimes you were very polite in your questioning. They're a bit more aggressive, and it's got to the point where, with our 10 years worth of data and knowledge and learning, we've actually tried to reclassify dissections into two types: the safe type and so type 1, we'd call it type 1 is safe to leave, and type 2 is you need a stent. So the type 1s, to my mind, would be the intimal tears that you get, so the flap running along the inside of the lumen, whereby you don't get progressive luminal compromise, you have TIMI3 flow, and you don't have contrast in the wall of the blood vessel. So the opposite of that, obviously, are the ones that you would need to stent. So increasing luminal compromise, so progressively over the next few minutes, would suggest to me that you've got intramural hematoma there. So that's the type of dissection that you can't leave. A big spiral dissection or something that's occluded, obviously you need to fix anyway. The other one, the really important one to look for in the setting of reduced flow, so you've got to have TIMI3 flow, anything less than that and you're interested. The other really important one is where contrast is hanging up in the vessel wall. If it clears quite quickly, that's fine. If it doesn't clear, again, that's a marker that if contrast can get in and isn't coming out, then blood can get in and won't come out either. So those would be the types of dissections that, again, will give you progressive intramural hematoma and shut the vessel within a few hours. So we've tried to reclassify it into two rather than these random 6 that people can never remember, with essentially those things that I told you. So the ones that are safe to leave are the intimal tears, the flaps that you can see, TIMI3 flow, no progressive luminal compromise, and all the contrast is clearing from the vessel and the wall. And that means you need to take your angiogram for a couple of cardiac cycles afterwards to see that it's all cleared. We are trying to publish that at the moment.
Great. I think that's important because I think we're using a very outdated classification. I agree with you. It has it's not predictive at all. Guillaume?
Yeah, hi. Very impressive talk, and think that balloon could be so useful so many ways. So very thank you for this. Just a quick question about the outcome. So you told a lot that we need more data on it, but it seems that there is many different outcomes also in the study that you show. So there is mortality and MACE at one here for debate and reverse study. There is the target lesion failure at one here for transform. There is also non-inferiority outcome for solution at one here.
Yeah.
What do you think about coronary imaging? What do you think about the best outcome? And for us as practitioner, what do you think we need to as a last outcome before including DCB in our practice, in daily practice? Thank you.
Well, that's a short question to end on. Thanks.
Sorry.
So Azim will know this because we both sat in the same room at PCR, which is there is going to be an ARC paper coming out
looking very specifically at endpoints in drug-coated balloon angioplasty trials. And one of the problems is, as you quite rightly pointed out, there are so many different ways of looking at it, number one. Number two, unlike when you're comparing one stent against another, here you're comparing two very different angiographic outcomes acutely against each other. And then at long-term outcome, I guess the most important thing is patient safety and efficacy of your treatment, isn't it? So I think the really important early outcome has to be a safety outcome, which should be picked up in trials and certainly will be picked up in the solution trial. And that actually isn't really comparing, is a DCB safe in the first day or first month to is a stent safe in the first day or the first month. Actually, what they're looking at there is how good you are at angioplasty. If you do a really good angioplasty with a balloon or with a stent, you will have a tiny percentage of people coming back in the first day or the first month with a problem. So the early safety step is actually measuring our angioplasty. It's not measuring the tools that we're using, which I think is quite interesting and perhaps challenging. The long-term data. So a few years ago, I asked Robert Byrne, who is very into a lot of ISR studies. I asked him what it would take for him to convert to de novo DCB only angioplasty. Hopefully he remembers this and doesn't tell me that I'm making it up if he ever sees it. But his comment was that if you could prove non-inferiority of a DCB approach at 1 year, he thinks that that's all that you would need. And non-inferiority I guess, has to be a composite endpoint, doesn't it, at the year? And so that will therefore take probably the biggest driver of our MACE or target lesion failure, whatever you want to call it, which is TLR, which is what all the other studies have used to push us towards stenting. So if we can show that we're as good as stents at a year, logically, we are then in a year in the realms of, I have a vessel that has some coronary disease, but no permanent implant, against a vessel that has a permanent implant with all the long-term complications that I've just shown you. And I think, the leave nothing behind concept at that point in time has to win. Yep. Does that answer your question? Okay.
Judah, did you have any questions? You were fairly quiet.
No, I think that was a wonderful talk and inspires us all to start using more DCBs. We can't wait to get them in the US. And I think all my questions that I had were asked by other participants.
Okay. Good. Simon, thank you so much. I think, we're probably going to ask you at some stage to maybe take us through a very image-driven clinical kind of talk, showing us dissections and showing us the different types of dissections that worry you and that you would think of stenting. That would be really useful. So I'll reach out for that. And once again, thank you so much for spending the hour with us. We appreciate it.
Pleasure. It's been great fun. Good to see you again.
Great. You too.
Okay.
Take care now.
Thanks.
Okay.
Bye.
Cheers.